Our next speaker is Adi Abulafia, who is from Tel Aviv. Adi is a young rising star in this whole area of IOL calculation and toric IOL prediction, and he's going to share with us some of the results of toric IOLs using the Barrett calculator.
Okay. Thank you, Doug, for your kind words. Okay, so modern cataract surgery have become a combined rehabilitative and refractive procedure. And toric IOLs have a major role in this new era, becoming the standard of care for patients with pre-existing corneal astigmatism who undergo cataract surgery. However, the results following toric IOL implantations are not always quite predictable. Surgically induced astigmatism, toric IOL misalignment, corneal astigmatism measurements, and the methods of calculation are all factors that might contribute to unexpected residual astigmatism. So today I'm going to talk about the latter two, and let's start with corneal astigmatism measurements. Now, there are many devices in the market which use different technologies to measure the corneal astigmatism. Most of them are measuring the anterior corneal measurements, but some can measure the posterior corneal as well. Furthermore, not all of them are measuring at the same location, and some will have better predictability and accuracy than others. So it is important to be familiar with your devices and to know their strengths and weaknesses. It is also important to validate your data, and useful checklists are available on Dr. Hill's website. Now, always be alert and try never to cruise on automatic pilot mode. I want to show you an extreme example of what can happen when one stops paying attention to details. Now, this patient was referred to me several years ago with a huge myopic surprise following an uneventful cataract extraction. Now, on a closer look, one can see that something is strange. A mean K value of 34 diopter is quite unusual. So we repeated the keratometry measurements of this patient, and to our surprise, there were more than 13.5 diopter difference in the mean K values. And apparently this lady was wearing her contact lenses during her pre-op evaluation. How bad is that? Now, you can imagine how unhappy she was with her outcome. And my take-home message is always be alert, validate your measurements. If something doesn't look right, repeat the measurements and try to figure out what's going on. Now, before determining the corneal astigmatic power and meridian, it is essential to make sure that we are dealing with the symmetrical and regular astigmatism. And then one should follow the methodology by Warren Hill of using primary and secondary supporting instruments. And we do that for determining the steep meridian. And we repeat the same process for the power difference between the meridians. Now, for our primary device, we would like to use the most accurate machine available. But as we all know, good repeatability is essential for high accuracy. So what we did, we evaluated the differences in corneal astigmatism measurements in 28 right eyes of healthy volunteers 1 week apart. And we did that by using the OWLmaster 500 and the LENSTAR devices for the same eyes. And in a perfect world, all these dots should be plotted against the 0 mark. But as you can see, this is not the case for both devices. However, the LENSTAR device had a significantly lower variance as compared to the OWLmaster. And when the LENSTAR was used, more than 96% of the eyes had a difference below 0.5 diopters between the two measurements, as opposed to about 78% with the OWLmaster. So what about accuracy? When we evaluated the errors in predicted residual astigmatism, following toric IOL implantation, the LENSTAR had a significant lower centroid prediction error and variance as compared to the OWLmaster. So let's move now for the methods of calculation. Now, today we know that standard keratometry and topography machines tend to yield inaccurate results in assessing the net corneal astigmatic power. It has been now 4 years since Doug Koch had reminded us the role of toric IOL calculation, the role of the posterior cornea in toric IOL calculation, and the next obvious step was to try to figure out how we should implement this knowledge in our daily practice. So one solution is to use intraoperative aberrometry. Another solution is to use standard toric IOL calculators with a nomogram like the Baylor. And a third option is to use the barotoric calculator. Now, as you heard, this calculator is available on the ACRS and the APSRS website, as well as on the LENSTAR device. Now, this is an all-in-one solution. It uses the universal 2 formula in order to predict the post-op spherical equivalent. It uses the effective lens position in order to calculate the IOL cylinder power correction at the corneal plane. And it uses a mathematical model in order to estimate the net corneal astigmatism by utilizing anterior corneal measurements. So this is one of our recent studies in which we evaluated the prediction of refraction outcomes with Toric IOL implantation by using different devices and different methods of calculation, including the bariatoric calculator. Now, this was a retrospective study, and it included patients who, 68 eyes, who undergone uneventful cataract extraction with the Toric IOL implantation. And for the measuring devices, we used the IOL Master, the LENSTAR, and the Atlas topographer. And for the methods of calculation, we use the Alcon Toric calculator, which uses a fixed ratio in order to estimate the cylinder power of a Toric IOL at the corneal plane, and the Holiday and the bariatoric calculators, which are using the effective lens position for the same purpose. Now, and what we found out is the combination of the LENSTAR and the bariatoric calculator yielded the highest proportion of eyes with a prediction error below or equal to 0.5, 0.75, and 1 diopter. Now, when we used the Alcon Toric calculator, both devices, the IOL Master and the LENSTAR, yielded against the rule prediction errors with a centroid of more than 0.5 diopter. Similar results were seen for the Holiday Toric calculator. However, using the bariatoric calculator yielded centroid prediction errors which were close to 0. Now, what about using standard Toric calculators with direct measurements of the posterior cornea? Now, theoretically, this should be the most accurate method in assessing the net corneal astigmatism. However, our personal experience with a Pentacam device was somewhat disappointing. In a different study with a similar design, we evaluated the accuracy of direct measurements of the posterior corneal curvature. And we did that by calculating the errors in predicted residual astigmatism in 99 eyes using the IOL Master and the Pentacam device. Now, when we used the IOL Master measurements with a Holiday Toric calculator, we saw against the rule prediction errors with a centroid of more than 0.5 diopters, same as we saw in the previous study. And by using the Pentacam device, using the total corneal refractive power as suggested by the manufacturer, the centroid prediction errors was slightly lower, but on the expense of higher standard deviation. Now, a combined vector of the IOL Master measurement and the posterior cornea, as was measured by the Pentacam, showed better results. However, the most accurate results were seen with the bariatoric calculator with only the IOL Master measurements. Now, these results suggest that using direct measurements of the posterior cornea by this device may not be accurate enough in this stage and should be addressed with caution. So, in summary, the outcomes of Toric IOL implantation can be optimized by using appropriate measuring devices and appropriate methods of calculation. Thank you very much.
Thank you, Adi.